Institute for Global Health seminar series of 2025. It's nice to see you all. I'm super excited. My name is Lynn Matthews. I'm a professor of medicine in the Division of Infectious Diseases. And within the Institute for Global Health, my job is I'm an associate director for research and partnerships and work with a great team. Hats off to Abril Agnew, who's one of our administrative team members who helps to organize this seminar series. And I am thrilled to introduce Dr. Lori Bateman. Dr. Bateman is an assistant professor at UAB in the Division of General Internal Medicine and Population Science. And she is going to be presenting with a whole team of folks who've been working on a project based in Alexandria University. And it's exciting because Dr. Bateman was one of our first pilot awardees. And this work kind of highlight some of the work they've done with that pilot award. And of course, I think they will be showcasing kind of how that has evolved in the other projects they've done related. So the topic is developing Egyptian investigators to explore colorectal cancer prevention knowledge and behavior. And I'll also make two other comments. One is that Alexandria University is one of our kind of key collaborative partners, in part because of the relationship that Dr. Bateman and others at UAB have with this institution. So it's exciting to see that. And two, if you feel inspired by this and are interested in how you could have a pilot award, I'm going to put in the chat the current link for those, because our applications for the next year's pilot awards are open now, due later in the month. I'm not going to say the date because I'm going to get it wrong, but later in February, it's a couple weeks away. And with that, I will turn it over to Dr. Bateman and her team. And thank you so much.
Oh, thank you. Thank you for that introduction. And I really do want to thank the Mary Heersink Institute for Global Health and Dr. Matthews for the opportunity to present findings that have emerged from our pilot project that was funded in 2022. And I think it's just really exciting to see kind of what has come from this really pretty kind of small pilot. So I'm really also grateful for the Egyptian collaborators that are here presenting. Most of them were trainees in the program. So I'm going to give a very quick introduction and I'm going to share my screen. And then I'll turn it over to our Egyptian collaborator, Dr. Karim Abd El Tawab. And then he is going to present our training program that was part of the grant. And then he'll turn it over to the trainees and the work that they've done as a result of that grant. So let me go ahead and share my screen. Okay. Sorry, I should have left it up there.
Sorry, and thanks everyone for joining. Just as we get the presentation on screen, I just want to say I've worked with the UAB team for quite a long time now on different projects, and it's been such a magnificent opportunity, both learning and just sharing this knowledge that I've learned with the rest of the team and other members. So it's been a great opportunity. So thank you.
I'll just quickly say that this pilot emerged from, other studies, but these are two kind of prior collaborations that set the stage for this pilot project. One goes back to 2014, and you can see, Egyptian and UAB investigators on that, and then there was another one in 2017. And I had the really good fortune to be able to work on that with just some amazing investigators here at UAB and in Egypt. And those projects were funded by the U.S. Egypt Science and Technology Joint Fund. And then this project, this is our team for this project. There's myself and Dr. Mona Fouad, who was a senior investigator here at UAB, and Dr. Walid Arafat, who's our senior investigator in Egypt. Dr. Barbara Hansen was our training coordinator, and then Dr. Karim Abd El Tawab. He's currently a clinical fellow at King's College Hospital in London, and he was really our point person, ran the program in Egypt, did a great job. At that time, 2 years ago, he was a senior oncology resident there. And yes, in 2017, he was part of our project. as a medical student. And so it's really, just been great to work with him on this project. So I will turn it over to him. I'll skip those and just go through.
Thank you so much, Dr. Lori, for your kind words. Yeah, it was definitely been a pleasure having worked with the UAB team, Dr. Mona, Dr. Lori and Barbara, and many others who have kind of been to Alexandria over the past couple of years since I've been a medical student. It's hard to believe it's already 2015 since then. I'm very excited to talk about the Colorectal Cancer Research Education Program because planning this project, we had a lot of mind, and there was a lot of caliber amongst young Egyptian researchers who were really engaged and wanted to come and do projects on cancer research and cancer prevention. And we thought this would be a great idea to kind of build their capacity in cancer research. So the aim of the program was to develop and implement a two-phase research training program for young Egyptian researchers, particularly tailored for colorectal cancer prevention, but that they can use the knowledge they've gained to do other researches and carry out other research protocols in other areas of cancer and cancer prevention. Phase one of the training was essentially about the research training itself. We had 2 in-person sessions. The first kickoff session was in Alexandria, and then followed by 6 other virtual sessions. And the last session was again another in-person session in Alexandria, Egypt. Phase 2 of the program was kind of putting what we learned into practice and the research practicum. The trainees then designed and executed research programs or protocols of their own, and were divided into 2 teams, the qualitative and quantitative team. Next, please. So here's a nice layout of the training curriculum. Like I said, we kicked off with the in-person workshop in Alexandria, Egypt, followed by 6 virtual sessions, and really it dove into kind of the essential skills for research, from quantitative and qualitative research methodologies all the way up to data analysis, writing and publication, getting your research published, but also with a flavor to cancer prevention, particularly colorectal cancer. Interestingly, we had almost double the number of applicants that we can take on board for this project. So we had a number of 25 to 26 spots available, because we wanted to make sure that we're able to deliver as much as we can to a small group as possible, so that they can really achieve the best and benefit from the knowledge being shared, especially being a pilot. But we were really overwhelmed with the number of applicants, so this was really exciting to see. Next slide, please. So phase 1 of the training was part of the program was the training and education. The first in-person session was mainly an orientation introduction to cancer research, a little bit of understanding about colorectal cancer and cancer itself. What are some of the social determinants of health, with a particular focus of the epidemiology of cancer in Egypt, as well as some ethical and responsible conduct of research with areas like good medical practice and others. The second in-person session was held a couple of months later in March 2023, and that kind of was a little bit more an extension of the virtual sessions that were carried out during the interval period or the interim period, with research project planning, principles and practical skills for to carry out interviews, study protocols and procedures, as well as holding mock interviews for practice, which the participants later on did hold the interviews with patients and doctors. So here are some pictures from our first in-person session back in September 2022. The invitation that was sent out to all our selected applicants. We've had on the top right, we have had Dr. Meha, who's the head of the IRB and the Ethics Committee in Egypt. Now she's actually chairing the National IRB. Dr. Mona Fuad in the next picture in the middle, talking about our collaborations, and myself in at the bottom right. More pictures really. It was such a lovely time. Dr. Walid Arafat, who's a senior professor and lecturer at the Clinical Oncology Department at Alexandria, talking about, again, social determinants of health and cancer in Egypt in general, and some engagement from the participants, which was really nice to see. more pictures as well. Dr. Barbara, Dr. Lori, who were there. We have a picture of our team in the center, and some pictures that the participants have kindly shared with us from their experience, which was lovely as well. So we've had the kind of phase one, which was, we talked about the in-person sessions, but also we've had virtual training or modules that was held online on Canvas website, kind of supported by the UAB. And we can see here that these are some of the discussions that we were having after the virtual sessions. And I think it was really helpful because the platform not only supported having the recorded sessions being there, but also we were able to provide some reading material for the participants to access really at any time, whether it was on their way to university or just after work. But it was also quite engaging because we've had these discussion groups where they had shared ideas and discussed questions about after every session. And when it was time to brainstorm about your research question, they really engaged on the platform, and it was very nice and easy to follow as well. And I think that was really interesting to see. So here are some pictures from the virtual component as well. We've had our meetings in Zoom meeting, usually held every other week on Fridays. And the modules were also, the online meetings were held, were recorded and were accessible on demand. So if anyone was not able to attend for whatever reason, whether it was clinical duties or university duties, they were able to then access it later, making sure that no one misses out on the teaching material being shared. Here, so some data from our kind of participants groups. We've carried out in our first in-person session, we've carried out pre and post surveys to assess the knowledge of the participants and how much that has changed after the implementation of the training program during the phase one and phase two. And surprisingly enough, we had a really good gender balance with 50% males, 50% females. And with only very few of them having some previous experience in colorectal cancer research training at all. So that was also nice to see. Next slide, please. We can here see some of the changes of the participants' understanding of the research components after the in-person session and the virtual sessions. So I guess most starkingly and most excitingly, a lot of them had developed much of the knowledge, improved their knowledge in quantitative research methods, study designs in particular, but even in the ethical consideration of research, as well as some of the clinical knowledge of colorectal cancer itself, which was also important to deliver not only practical skills on carrying out research, but some clinical and medical knowledge on colorectal cancer, because everyone came from various backgrounds and not everyone had the same basic knowledge of colorectal cancer and colorectal cancer prevention. Next slide, please. Again, talks about some of the misconceptions that the participants have had about colorectal cancer, and this assessed their knowledge prior to and after some of the modules on colorectal cancer screening and the risks of colorectal cancer and the prevention. I guess most notably is that a lot of the participants had thought that eating spicy food is a risk for colorectal cancer, which again was proved not entirely accurate. And it was nice to see how the change in mentality and knowledge about colorectal cancer improved after the sessions. Phase two of the program was really putting the research into practice. So after completion of the second session, the second in-person session, the team was prepared to assist with IRB protocol submissions, recruitment for each of the research groups, data collection, interviews, and the manuscript writing. And the participants were divided into two teams, the qualitative team and quantitative team, both equally, and asked to come up with their own questions, having had this knowledge now, to come up with their own questions and encouraged to kind of brainstorm and come up with their own questions that they would like to research. The qualitative team had come up with wanted to explore the experience of the Egyptian colorectal cancer patients from the pre-diagnosis to the diagnosis, treatment, and to survivorship phase, whereas the quantitative team really wanted to understand what do Egyptian oncologists know regarding the optimum nutrition and physical activity for patients diagnosed with colorectal cancer to best meet the patient's needs from from prevention to the early detection. These are some of the program outcomes, and I'm really proud and just to see that we've had published abstracts, we presented poster presentations in several conferences, some scientific presentations as well, with 2 papers currently under review as well for that have been submitted. So the participants have had the experience of carrying out the programs, but also all the way up to submission. Many of them have been the corresponding authors, and I think this is really the core and essence of the program, is making sure that they have this experience and knowledge that they can carry on forward with in the future. So in conclusion, incorporating public health research training during medical education in low and middle income countries can reinforce cancer prevention research, as we can see as a live example from the experience of the participants in Alexandria University Hospitals. Training can increase the pool of researchers, and this was our ultimate goal, and ultimately lead to reduced morbidity and mortality from cancer and chronic diseases. Finally, here's a picture of our lovely team with Dr. Lori, Dr. Barbara, Dr. Waleed's not in the picture, but we have Dr. Mona Fuad from UAB as well, and the rest of the members of the qualitative and quantitative team. Thank you very much.
Thank you so much, Dr. Karim. All right, well, so next we're going to see the findings from the quantitative team. So as he was saying, we divided the 25 students, they divided themselves into, or trainees, into 2 teams, and each explored a different research question. And so this one is physician level barriers to colorectal cancer screening for Egyptian patients at primary care clinics. And presenting are Karim Abd El Tawab, and then Amal Asi, and Islam Apukandal.
Okay, thank you, Dr. Lori. Hello, everyone. This is Amal Asi. I am a 4th-year medical student at Alexandria University, Faculty of Medicine, and I'm so happy to participate in this opportunity today. Next. Special thanks, of course, to our co-authors. Next. Today, I would love to introduce to you our research program in addressing physician-level barriers to colorectal cancer screening for Egyptian patients at primary care clinics. As we all know, a large part of patients' compliance and knowledge of screening lies within the knowledge and advice shared by their physicians. We identified some of the current physician barriers to screening, which were patient health complications, time constraints, logistical hurdles, assumption from some physicians that screening will be addressed elsewhere under gastroenterological care, low familiarity with colorectal cancer screening guidelines, and low knowledge of facilitating screening facilities. Next. So why is this study important? In view of ongoing national initiatives to promote healthier lifestyle and cancer screening, it was necessary to explore obstacles to promotion of colorectal cancer screening amongst physicians as being the front line for implementation of such initiatives. So we aimed for assessing physicians' awareness of colorectal cancer risks and preventive measures, as assessing physicians' adherence to screening guidelines, and examining obstacles faced by Egyptian primary care physicians in promoting colorectal cancer screening. Next. We asked the physicians if they know that the 100 Million Healthy Lives campaign was the 100 Million Healthy Lives campaign included cancer screening and treatment as part of this program. And we all know that the very successful campaign that was established in 2018 to address the challenge initially of HCV and non-communicable disease, it also included cancer screening as part of this program as well. Next. Now I will leave you with Dr. Islam. Thank you.
Thanks to my friend Amal. I'm Islam Apukandal. I'm a 5th-year medical student at Alexandria University. I'll be talking about the methodology section. Our study was a cross-sectional study conducted at Alexandria University Hospitals from September 2023 to January 2024. We included residents in non-surgical departments affiliated with our university, and we excluded junior doctors who are currently doing their intern year and seniors who already completed their boards. Next, please. Our questionnaire was a self-administered online questionnaire and was delivered in English. Some of the items included were socio-demographic data, knowledge of CRC, optimum nutrition and physical activity, and knowledge about the 100 Million Healthy Lives campaign. Next, please. Moving to the statistical analysis part, we used bivariate statistics to assess the associations between demographics, knowledge scores, attitudes, and screening behaviors. And we used the chi-square test to assess for significance. And we set our significance level at 0.1 because our sample size was small. And we dichotomized the questions about knowledge and attitudes to yes and no questions. And we set the passing grade for the knowledge and RAS questions to 60%. And we used SPSS software to analyze our data. Thanks, and I'll leave you with Dr. Karim.
Thank you, Islam and Amal. So some of the results that we had from this research of this project, the demographics of the residents were, as you can see on the screen, 79% were female. The majority had already been working in tertiary center, but have had some experience working in primary care as well. And we had a good even distribution of medical specialties from rheumatology, cardiology, nephrology, and others. Next, please. So perhaps two of the most interesting findings out of this survey was that 55% of the residents had failed the CRC knowledge test, even though they were practicing in primary care settings or tertiary care settings. As Islam had mentioned, the passing mark had been set at 60% for the colorectal cancer knowledge test. And most importantly, as we can see again on the second pie chart, is that 51% of the participants had only heard about the Million Lives campaign, with 49% that have never heard of it, which could really give a clue about whether or not they had been referring patients to for screening and what knowledge they had about the existing services that the 100 Million Healthy Lives campaign had to offer. We asked the question, where do you like to get your updated colorectal cancer information from? And surprisingly, 67% had mentioned the medical school curriculum, but by the time they had been practicing medicine, whether in the primary healthcare setting or in a tertiary setting, that would have changed dramatically. The guidelines for screening and even the diagnosis and treatments would have changed dramatically. Scientific websites, 30% had referred that they would like to refer to scientific websites, with 24% saying they received the knowledge from their medical colleagues. Next, please. Physician screening behaviors were divided into yes, no, or never, and we've asked them who did they refer for colorectal cancer screening. And once you would expect most of the patients who have suspected colorectal cancer, either due to their symptoms or their family history, would be referred, only 16% have recommended screening to asymptomatic patients who did have either family history or were at high risk of malignancy within the age group, as stated by the guidelines. Next, please. Also helping us identify if we were to implement a knowledge campaign, how would they prefer to receive this colorectal cancer training. And it was interesting to see that about 70% of them had preferred in-person meetings, with about 30% preferring online sessions and only 20% recorded videos, which would be important in trying to identify how we would plan our next future health programs. In conclusion, I guess, next slide, please. Our findings suggest that there's a potential gap in awareness and adherence to colorectal cancer screening amongst the residents, with significant proportion not recommending asymptomatic patients for screening. There is a need for targeted educational interventions to improve understanding and adherence to screening protocols, and almost half were not aware of the 100 million healthy lives campaign again. Our recommendations suggested targeted educational programs for residents and patients with enhanced accessibility for screening tools, to embracing evidence-based strategies to promote prevention and early detection of colorectal cancer, and as mentioned, evaluation of gaps in the colorectal cancer knowledge, attitudes, and practices among staff at other multi-center practices in Egypt, in other hospitals across Egypt, would also be very relevant and helpful to guide further interventions to address those gaps. Here are some of our references as well, and thank you very much.
All right, thank you so much. Now I am going to introduce the presenters for the qualitative part of the project. And this is, they've entitled their presentation, Journey to Wellbeing, a Primary Exploration of Diet and Physical Activity Among Egyptian Colorectal Cancer Patients, and Insights from Semi-Structured Interviews. And I'll remind you that really appreciate these folks who are presenting, but they're representing a team too. So they've got their team behind them as well. So for this presentation, we have Mariam Mansour, who's a house officer at Alexandria University Hospital, and Aya Khalid, who's a fifth-year medical student at Alexandria University, and Assam Gabriel, who is also a house officer at Alexandria University Hospital. So I will turn it over to them.
Hello, everyone. Thank you, Dr. Lori, for the introduction. My name is Mariam Mansour, and I will start our presentation about the qualitative part. To begin with, colorectal cancer is a major health concern. It's the third leading cancer worldwide, and that's the second leading cause of cancer death. But here in Egypt, we have an alarming trend of patients who are diagnosed before the age of 50, and most of these cases are diagnosed in the later stages, with impacting the survival rate. Next. With that in mind, our study aimed to go in depth to understand how cancer patients in Egypt perceive the preventive diet and physical activity behaviors. We wanted to understand their real-life experience with this behavior, and what challenges they faced, what behaviors helped them adapt from pre-diagnosis to survivorship. Next. To achieve that, we conducted semi-structured interviews at Alexandria University Oncology Clinic. These were in-depth one-on-one conversations lasting between 60 to 80 minutes, exploring patient journey from pre-diagnosis to survivorship with a special focus on preventive behaviors. We continued interviewing several patients until we reached theme saturation to ensure that we captured various perspectives. All these interviews were conducted in Arabic, audio recorded, transcribed, and analyzed using thematic analysis. Beyond the methodology, beyond the methodology, this experience actually helped us reshape our interviewing skills. We learned that interviewing is not just about asking the right questions, it's also about how to effectively listen to the patient telling you their journey. One of the simple techniques we were taught that really helped me in my daily practice right now is the 5-second pause. Getting comfortable with silence in interview is an invitation for patients to give, and honestly, most of the profound responses we got through those interviews were after a pause of silence. These silence were inviting for patients to open up more. Next. Before starting our studies, we obtained ethical approval to ensure all research practice meet the highest standards. After that, with every participant, we provided an informed consent in Arabic, ensuring that they fully understood the study purpose, the role, and the right to withdraw at any time. And after that, we implemented strict data security measures to protect patient privacy, ensuring that all information remained anonymous and securely stored. From now, my colleagues will walk you through the results we got from this study. Thank you.
Hello everyone. Thank you, Mariam, for your interview. Um, um, I'm glad to be here, honestly. So, let's go through our findings. Our key findings was that we worked with 19 participants, 12 men and 7 women. All participants came from low-income background, and 80% were unemployed, whether they lost their job or they were disabled. Alarmingly, almost nearly half of our participants were diagnosed at advanced cancer stage, whether stage 3 or higher. Actually, these findings made it clear for us we need a comprehensive understanding for barriers to early detection and care. Next. To better understand these challenges, we use the socio-ecological model. Socio-ecological model was first introduced as a conceptual model for understanding human development in early 70s. This framework looks at how individual behaviors and outcomes are shaped by multiple levels of influence, from personal factors like income and education to broader systems like community, organization, and policies. Socio-ecological model help us to see that cancer prevention is not just about individual choices. It's about the complex web of factors that shape those choices. Next. By applying the socio-ecological model in our findings, we saw that how barriers and facilitators affect colorectal cancer patients through their journey from diagnosis, treatment, lifestyle till survivorship. At the individual level, we saw lack of awareness and fear of colonoscopy, unemployment, and poverty. We saw family and peers' impact on health choices at the interpersonal level. We saw culture, belief, and stigma at the community. We saw misdiagnosis at the organization. We saw absence of clear screening policies and implying it, and lack of health insurance at the policy level. These layers do not operate in isolation. In fact, they interact. For example, unemployment and poverty at the individual level was mainly impacted by unsupportive work environment for colorectal cancer patients and patients with colostomy at the community, which was worsened by the lack of insurance and high cost of care at the policy level. On opposite note, NGO and charity support was a huge facilitator at the community level for mitigating the impact of poverty. Also, embarrassment and fear of colonoscopy at the individual level was fueled by the conservative nature of the community and cancer stigma in our community. Here, I will leave the space for my fellow to dive deeper into results and quotes from our participants. Thank you.
Hi everyone, I am Aya Khalid, and I will walk you through our most important findings, starting with the facilitators for optimal patient care at the individual level. Firstly, upon receiving the diagnosis, participants exhibited a spectrum of reaction. However, a common thread of resilience and acceptance among them strongly prevailed. Then, the desire to recover and the good perception of a healthy diet and physical activity. At the interpersonal level, patients received social support from family and friends, which, as they described, was crucial for them. In the following statement, this is best illustrated. I live with my family. My siblings never leave me alone or in need. My friends always visit me and keep up with how I am doing. Then the motivation from survivors. At the health service organization level, the positive doctor-patient relationship, while patients express gratitude for their physicians and the whole healthcare team despite lacking of resources. Then the doctor's recommendations for eating healthy food and being physically active. At the cultural community level, we have the religious resilience within the community and the financial support from non-governmental organizations. At the health policy level, the free healthcare access and chemotherapy. Moving on to the barriers. At the individual level, lack of awareness and neglect of symptoms, Fear of colonoscopy, and this was a major issue. A patient shared describing how her emotions controlled her. This is a quote. I kept complaining of rectal bleeding for a whole year, afraid to do the colonoscopy as I imagined it would kill me until my doctor advised me to get it done. Big problem, of course. Then the loss of appetite and as a consequence, decreased physical activity during treatment. And the unemployment and low income. At the interpersonal level, we have the peer's fear of colonoscopy and the fear of peer judgment. At the health service organization level, the misdiagnosis, the lack of structured diet and physical activity programs. Well, although doctors' recommendations were the primary source of information regarding diet and physical activity, in most cases, they were neither specific nor tailored to patient to their need. Then, the lack of comprehensive guidance in treatment journey and the lack of preparation and patient education. At the cultural community level, we have beliefs and cancer stigma. At the health policy level, the unclear policies for CRC screening protocols and lack of equipment. Well, we interviewed 2 patients who had a strong family history of the disease, yet they were never advised nor told to ever undergo a screening or a follow-up. Then the lack of insurance and high costs and lack of healthcare services in rural areas. As a conclusion, the need for early detection of CRC is increasing, and this can only be achieved through expanded screening programs and more health campaigns. And that led us to appreciate and acknowledge the grant we received from the Mary Heersink Institute for Global Health that has supported us in conducting this project that will surely contribute to future effort. We believe with more studies, we can influence all the level of the social ecological model and especially the policy level. As for me, taking part in this project opened doors I never knew existed. It has challenged me and to actively ensure and consider the patient's optimal care while valuing the importance and efficiency of early detection and cancer prevention. My colleague Asim also shared his reflections saying, and on behalf of everyone of the team, thanks to the team mentorship. Can we have the next slide, please? Of the reflection. Yes. Thanks to the team mentorship, my colleagues and I are now pursuing further research initiatives and international collaborations. That's it, and thank you.
All right. Thank you so much, each of you, for presenting, and that concludes our presentation.
That was amazing. Wow. I'm so impressed with all of this work and that you all, I don't know how many people just presented, but there were no technological glitches. That's like magic. So wonderful to see all of this. We have a little time for questions. So I encourage people to, I guess you could rate, if we stop screen sharing, people could raise hand or just unmute and ask your questions. Or type in the chat and I'll repeat it. Are you all hearing me? Dr. Bateman was briefly frozen. Yes. Okay, great. But I'll start. I have a question. And this is either for Dr. Bateman or it might be for Dr. Abd El Tawab, or it might be for all of you. I don't know. But my question is, this is work you're presenting that's been going on for several years. And you've engaged with so many medical students over like a long period of time, and medical students are so busy. And so I guess I wondered, like, if you could say a bit about how students have been able to be engaged in this work, like longitudinally, and sort of how that's been facilitated either through sort of the structure of like what the research curriculum looks like at Alexandria or your team, or I would just love to hear a little bit more about how you've kept this kind of cohort of medical students engaged over this longitudinal project.
Yeah, so I'll say that so the project from the MHIGH Institute, those 25 students, they pretty much started then in 2022. But I mean, that has been 2 years and they're still engaged. So I'm actually quite amazed myself, and especially people, students who have been now they're practicing physicians and they're still engaged. So I'm going to actually turn that over to my co-presenters because they have personal experience with that. But so let me go ahead and let them talk.
Thank you, Dr. Lori. Yeah, I think it's definitely not a very easy thing. I have to say that for the MHIGH grant or project in general, we did have a mixture of medical students and interns or those going through transitional year, as you would call them in the US. So some of them did have some time to come and engage. But I think part of it is because our university places a lot of attention on trying to enhance extracurricular activities, doing research and things like that. And engaging in activities like that was always seen as a positive point for the medical students in building, whether it's their curriculum vitae or just being part of their school curriculum. I don't know if any of if you guys want to talk about it, Amal, Mariam, and Aya, Asim. I mean, I know some of you Islam as well. You're still 4th, 5th year medical students. How do you want to reflect on how do you find the time, maybe, or how did you find it during the past 2 years?
I joined the program when I was in the 5th year, and we have the bi-weekly meetings. So the spaced meetings allow sometimes in between to revise the material over 2 weeks. It was reasonable time. And honestly, I was motivated. I thought that there was a clear structure, everything, and that the bi-weekly meeting made us anticipating for the next meeting. So I think the motivation part was the most important part. Yeah, it took us a lot of effort to do some extracurricular activity, but I'm honestly happy I was a part of it.
Thank you, Mariam.
Well,
go ahead.
Yes, well, I joined as well in my 4th year of mid school, and now I'm a medical doctor. I'm a house officer at Alexandria University, and we're still working together. And it was a major experience in my career. I believe research is a very important part of the development of any medical doctor. And Dr. Laura and the rest of the team at the program itself, it shaped my critical thinking process and my scientific background when it's come to research. Just after the project, just after 1 year of finishing the training, I started other projects, other funded research projects, and we're still working on it. I'm still working with Dr. Lori. I don't think any doctor should stop research because it's a very important process in medical and as a medical doctor.
Thank you.
Thank you, Asim. Yeah, I guess it's very nice to see that even after the program has kind of come towards its tail end, that some of the participants are engaging in projects outside just the colorectal cancer prevention and have kind of carried this knowledge that they've gained into other aspects, whether it's in the clinical practice or just research. So it's really nice to see.
And I will say that I think that the support that we have from our Egyptian collaborator, Dr. Walid Arafat, is really helpful too.
Definitely.
He's very supportive of the work that we do and encourages his trainees to be involved.
Hello everyone, can you hear me? My name is Dr. Fawzi Naga. I'm part of the quantitative team. Yeah, I would like just to add. Of course, I would like first. I would like to thank my colleagues for their work and for their sharing of our work. Also, I'd like to share my sole experience that I'm a gastroenterology resident right now. That's why CRC is a very important topic. That's why I keep. That's what helped me being engaged with such topic. I would say during my first year residency, I can say that I have seen more than 50 colorectal patients till now in my first year of residency. It's a very, very alarming sign. That's why I really appreciate our my colleagues' work. And I feel that's why that's what keeps me motivated till this moment to be part of this great project, to be honest. Thank you. That's why I would like to finally again thank all my colleagues for their support and our mentors like Dr. Walid, Dr. Mona, Dr. Lori, of course. I don't want to forget anyone. Thank you so much.
Thank you, Dr. Fauzi, for saying something. Yes, he is an integral part of our team too. Thank you for sharing that.
I have another question, but I want to make sure others in the audience have a chance. Do folks have questions? Feel free to come off mute and ask or type in the chat.
It looks like Dr. Tita might have a question.
Go ahead, Dr. Tita.
Good morning, good afternoon, everyone, and Lori and team, Karim and everyone. Thank you for this presentation. My name is Alan Tita. I'm the director of the Mary Heersink Institute for Global Health, and just want to congratulate you all on this presentation. It's really terrific to see how much has been done over this period of time. So my question is, given what you've been able to accomplish over the years, what would you do differently, right? After going through all this, and then what are the next steps to this, right? To continue to have impact. Again, thank you all. Congrats.
What would we do differently, folks? I haven't really thought about that. I think I would have been prepared for some of the barriers that we did face. We had difficulty with, for instance, getting funds to Alexandria University, and that was in the first few projects. This one, we learned about petty cash accounts and ways to do those kinds of things. But I think there were some logistical challenges for sure that we've learned from. And yeah, others may have something to say to that, but I'll say that our next steps are that we did have an unfunded R01. We submitted an R01 with my team, our team from our STDF grant a few years ago. Well, it was in 2022, I guess, at the beginning of the year. And so part of this actually is we're going to be able to use some of this pilot work in the resubmission of that. It'll be submitted under a different like NOFO, but we do have plans in place to submit that again based on some of the findings here and some findings we found from the other projects. So yeah, our next step is to submit an R01 and implementation science, focused on implementation science.
Yeah.
And some other things have happened too, like in that they mentioned that now colorectal cancer screening is included in the 100 Million Healthy Lives campaign. But something really important that we found is that, physicians may not know about that campaign. And so that's an important place for intervention.
Yeah. So Lori, I was looking to see whether anyone else was going to jump in, but that sounds terrific. And we anything we can learn as an institute from the logistical challenges early on. We, as you know, we set up a task force that was supposed to help us make some progress with respect to global health work, and those are the kinds of things that we need to continue to address. Then, we would love to continue to engage and collaborate with respect to helping move grants forward. We are setting up infrastructure to help facilitate these kinds of things and collaboration. So as you move forward with that, please keep us in the loop. Again, congrats, everyone. Yeah.
Thank you. Thank you so much.
I thought someone else had a hand up. It might have been a retained hand up. Lori, a lot of I am not a colorectal cancer specialist, but I take care of patients, and it sounded like, and colorectal cancer is also very common here. And it sounded like a lot of the barriers were similar to things I hear from patients here in Alabama. And I wonder, Lori, if you see, if any of your work is sort of thinking about sort of similarities and designing interventions that could work in many different contexts.
Yes, that is something that we're thinking about for sure. And there are overlapping barriers. There's significant differences though, and I think that does stem from the context. Several, and folks here can share, but I think that the stigma and the fear associated with colonoscopies is much larger there. And the other thing is the funding isn't quite there for colonoscopies either, for preventive, at least in, sort of screening, primary screenings. And so I think that's one thing. I think that also physicians are really don't tend to refer for screening there if patients are younger, even though a great majority, there's a lot of young colorectal cancer patients in Egypt. So I think that the cultural fears that we've uncovered and exist in Egypt around cancer itself, and it's like kind of fatalistic almost. Well, if I don't know about it, then I don't have it. And then again, the fear of the colonoscopy is pretty great there. Any other, you all want to jump in?
No, I think you covered pretty much a lot of it. I agree. There's definitely a lot of stark differences between here and in Alabama, but I haven't practiced there. But I think a lot of the barriers, just looking at literature, a lot of the barriers to colorectal cancer screening and even screening in general seems to be common across different cultures and different kind of borders as well. Even when it comes to breast cancer screening, just like what you said, if I don't know about it, then I don't have to worry about it, or I don't need to kind of intervene. A lot of it is cultural barriers as well, and whether I'll be able to sustain treatment if I were to be diagnosed positive, especially in places where finance and not necessarily finance, but health finance and medical insurance is not entirely covered. So that definitely becomes a barrier, but there are also a lot of similarities. I agree. I just wanted to add one thing to Dr. Alan Tita's question also about him asking what would we do differently, because I, thinking about it and having flashbacks of our early phases, I think this was a really beautiful learning experience for all of us. But I remember Dr. Lori, myself, and Dr. Barbara trying to sit down and come up with the curriculum and looking at other curriculums and things like that. That was definitely a learning opportunity for myself. And I think perhaps having someone who, or engaging more people who might be more focused on the medical education aspect rather than practitioners might also help enhance the curriculum and the way it's been delivered. But I think we did a good job.
Wonderful. Well, thank you all so much for your work and for sharing. And Lori, thank you for kind of organizing this whole group presentation. This is really wonderful. I think we all learned a lot. I did put in the chat the current RFA for global health pilot grants. I'll put it again because sometimes if people join late, they don't see that. And then I'll just share that our next MHIGH seminar series will be the first Tuesday of April, which is April 1st. And so keep a lookout for announcements about what we'll be sharing then. I think we're still working on it. But thank you all so very much and congratulations and take care.
Thank you so much. Thanks everyone for presenting.